Aaron and I are going to be talking a little bit about our system that we're developing. It's 3D ultrasound, but it's really an ablation system that in particular we're looking to apply for liver tumor ablation guidance. Here are disclosures. So when we talk about percutaneous ablation, I'm talking specifically percutaneous ablation of cancer. So this is an established therapy where basically we take a needle, put it through the skin directly into the tumor, either in the liver, kidneys, also done in lungs. And the tip of that needle, instead of doing a biopsy, collecting a sample, it'll actually either heat up or freeze and essentially kills all the tissue that are around it in a particular direction. Actually, if I've got there. So you can see we essentially have an ablation zone here, and that anything that's inside that area will die. So the nice thing about this is a procedure that can become done as a day procedure. We actually don't put the patients to sleep, just give them some medication to make them kind of drowsy, and they go home that afternoon with their cancers essentially dead. And so obviously we need to get the needle to the target somehow. So typically this is done either under ultrasound guidance or CT guidance. So you can see two examples here. The one on the left is under ultrasound. You can see, I don't know if I can show that. We've got our needle here inside the tumor that's around it. And conversely, we've got the CT. There you can see the needle going in and there's a tumor right up here. So, how do we decide one versus the other? Well, a lot of centers will do these procedures under CT guidance. It has a lot of benefits of being able to see all the anatomy around it. But, we feel there's a big motivation for us to be using ultrasound when we can to guide these ablation procedures. In addition to ultrasound being real time, no radiation dose to the patient or the operator, one of the big benefits that we see is that when we're doing an ablation procedure, especially under CT, it often takes, we typically book 2 hours, but it can be the shortest I've seen is an hour and a half, up to 3 hours. So to put that in context, if we're taking a CT scanner time for 2 to 3 hours, we're actually replacing the equivalent of anywhere from 6 to 12 diagnostic scans. So 6 to 12 patients in the same time as doing one ablation could have had their diagnostic scans done. And to give you a context, I know 2 years ago, I don't have the updated numbers, we were doing 200 ablations a year. So you start factoring that across the LHSC system, you're replacing a lot of patients' diagnostic scans if we do this under CT. So we feel that not only in our system, but I think systems elsewhere, if we can develop a system under ultrasound where we can do these ablations, that will likely increase the overall access to the procedure. So what are some of the challenges with ultrasound? I'm going to use the terms 2D ultrasound, which is really just the conventional ultrasound that we use routinely. Well, in some cases, the tumors are difficult to see. So this can either be because the tumors look similar to the background tissue in the liver. Sometimes they can be located in a spot that's difficult for us to image, kind of higher up in the liver dome, or if we're doing the kidney, some of those posterior medial areas. And there can also be tumor mix. So a lot of our patients, if they've got liver cancer, a good proportion of them will have liver cirrhosis, which can have its own nodules that can almost mimic cancer itself. So differentiating what we need to target can be a challenge, and visibility. Other thing is needle tip direction. Sometimes we need to make sure we're going on the safe path, make sure we're getting in the trajectory of our needle as we're inserting it, that we're going to basically get to that deep tumor, and make sure we get right into the center of the tumor when we're placing the needle. And lastly, we need to confirm that our needle is in the center of the tumor. As you can imagine, we don't want to be on one side of the tumor or the other, because then we may risk leaving some tumor behind once we're done the ablation. And that can sometimes be challenging to assess, particularly if we're in the liver. Sometimes we're imaging between the ribs. We only have one direction where we can actually see with the ultrasound probe. So what we're proposing is that we can use 3D ultrasound to help address some of these things. So what are the benefits of 3D ultrasound? We had a great presentation earlier on 3D ultrasound in the breast. The same concept really applies here when we're looking in the liver or the kidney. It provides us that volumetric information that we don't get with 2D ultrasound. So that allows us not only to see the plane that we're imaging, but we can slice it in other directions to really ensure that our needle is in the right position, that we're going to have good coverage. And our hope is that this will ultimately reduce some of our operator dependence. We've done some studies where we've looked at needle insertions and multiple operators, and afterwards we don't know who did the actual procedure, but usually looking at the video as that needle is going in can kind of tell whether it's been one of our trainees that's been putting the needle in versus one of the experts based on how well we're seeing the needle. So there is definitely, even amongst experts, some operator variability. And so the benefit with our 3D ultrasound system that we developed, it's a mechatronic system that you can see here on the bottom row, where basically it takes a standard 2D ultrasound probe, and then we'll just sweep it through a space and can acquire an image basically within about 5 or 6 seconds, actually, when we use it clinically. And like I said, this is compatible with all probes. And we've designed it in such a way that if you see on the right, so we actually have two angles, or two scan approaches, one where we just tip around a point, or the other one where we can actually translate and get a wider footprint as we gather. So we'll pass it over to Aaron for research.
So dealing with this challenge that they presented to us, we began to develop a system which involved both mechanical devices and a lot of software. So the system, I'm not going to describe the complete system, but just to give you in this slide some of the key elements that both I and Derek will describe. So you see the task, we have to increase the tumor visibility. We have to improve the needle guidance or provide information because sometimes the needle being at an oblique angle to the ultrasound transducer is not very visible. So can we improve the visibility of the needle going into the liver? We need to confirm the position of the needle prior to ablation with location within the tumor, and then integrating the whole system and testing the complete system in a clinical trial. So first, in terms of the improve the tumor visibility, so this is a case of, you can see in the CT images on the left side, post-ablation in the top view, it's quite clear, but in another image in the bottom on the left side, you can see there's another lesion. And so in CT, they're visible, but in ultrasound, if you look at the arrows, where is the second lesion, the one on the bottom? Where is it located? So it's quite confusing because you can see the post-ablation region, but where's that second lesion? So this is the challenge for one of the challenges. Is it that one or that? So our approach is to integrate and fuse 3D ultrasound images and 2D ultrasound images to the CT image, the diagnostic CT image, to avoid this confusion. So there, by fusing and overlaying ultrasound on top of the CT, we can identify the location. So how do we do it? So this is a problem of a multimodality deep learning-based registration. So we can collect either MRI images or CT images for our algorithm, register them into 3D ultrasound. Advantage is we have now a 3D image, a 3D ultrasound image to register to a 3D MRI or 3D CT, which is much easier than just a 2D image registration. And since we have a 3D image registered to the MRI or CT, 2D images can also be extracted because it's essentially with both the 3D ultrasound and the 2D ultrasound are in. The coordinate systems are the same, so we know the exact location in space, and then overlay it over the CT. So how do we do it? So we use basically a deep learning algorithm to segment the vessels in CT or MR and the 3D ultrasound. So in this case, CT and ultrasound using a well-known UNet algorithm. Once we segment and we go through a course and find alignment of the vessels. Once we align the vessels, then we have the coordinate systems of the two images fused or registered. So the question is, how accurate is it? And so we have performed this procedure, performed the imaging on a number of cases, and looked at various fiducials in the anatomy or in ultrasound and CT that we can identify. And you can see the errors in our registration of the order of about 2 or so millimeters, 2-3 millimeters. And on the right side, you see some of the cases, the registration. And in fact, you can see the outline of a tumor identified in ultrasound in blue and in CT in red. So you can see they're on top of each other, but slightly displaced from each other. And that's the measurement of the accuracy that we're reporting as an example. So you can see that it's quite good, but there's still a little bit of room for improvement. So the other task is needle guidance, to be able to track the needle. So now we are tracking it completely based on the images, no external, no additional hardware, no additional cost, just giving the ultrasound imager, the sequence of ultrasound images in real time to a deep learning model, and it would find the needle. So this is an earlier application of this kind of approach, and you can see that the algorithm. Let's see if I can run the video again. So you can see it works quite well, but the algorithm does get confused. You can see the needle gets kind of, the algorithm thinks it's somewhere else in the incorrect place. So this is what we have developed in the past, but now we know why the problem was. So now we have developed a new algorithm with memory. So basically it takes the video sequence, the ultrasound video sequence, and has memory from previous images to the next image, because there's continuity in the needle. Of course, the needle is straight or should be straight, and it should follow in some kind of sequence in the continuous ultrasound images. I'm not going to describe the algorithm, but it's working much better now. So if I can. So you can see a couple of cases of needle tracking. So you can see at the bottom the errors, the angle, the trajectory we can identify very accurately. It's less than 2-degree error. The tip location is critical. Of course, the tip is very difficult to identify. The shaft we can identify fairly accurately, but the tip is the challenge. The error we have currently is about 2.8. It's a little bit less than 5 millimeter error. And I believe that is because we are including in the calculation for the error the early look phases of the needle insertion, which could be more difficult, but the later phases could be easier. So we have to still improve a little bit, but we're getting there. As you can see, we can track the needle purely on the ultrasound data.
So moving on to kind of our task number 3 is basically confirming where our ablation needle is. So, I'll show kind of an example here, and I talked to the fellows. We're essentially looking at when we do a procedure under ultrasound guidance, you can see the tumor there on the image on the left, and we can see the needle going in to the tumor. And then how do we decide if we're ready to ablate? Well, literally we walk over to the ultrasound console when it's frozen and tell the needle, okay, well, we know the center of the ablation is going to be about 1.5 centimeters from the tip. Okay, there's 1.5 centimeters. And we know the radius of that ellipsoid, which you can see on the right, we know it's about 2 centimeters. Okay, it's about there. Okay, yeah, it seems like the tumor is covered. Let's go ahead and ablate. But really, we're trying to recreate that ellipsoid volume, make sure that we have complete coverage of the tumor. And that's something that's currently lacking with our 2D approach for ultrasound guidance. So the benefit that we have with a 3D ultrasound is that we can not only get the volume, where we can actually slice through and we can see the needle kind of within the tumor. You can see it's a little hypoechoic, is that tumor around the liver. We can also identify the needle, overlay it, and also overlay the expected ablation volume. Now we're able to see not only in one plane, but in all directions, will we expect to have complete coverage of that tumor based on our needle position? We can make that decision before we start the therapy, and then make any appropriate adjustments that we need. And so here you can see just going, this is orthogonal, we're going through the ribs. This would be a direction that we would not be able to image directly with the ultrasound itself. So really the question is, how good are we at doing our technique on the left with 2D ultrasound. And can 3D ultrasound improve the current standard? So we actually did a bit of a feasibility study, a clinical trial. We had 12 patients that had either HCC or colorectal mets within the liver. And we did the procedure essentially entirely under 2D guidance. So the operator placed the needle into the tumor. Once they felt happy to go ahead and ablate, we did a 3D ultrasound. Wasn't reviewed at that time. It was just done, can we, from a workflow standpoint, acquire these images effectively? And then what we did was after the procedure, after the ablation was done, we looked at the 3D ultrasound. And we had, as you can see the image on the right, we outlined not only the tumor, but also the ablation zone that was expected. And so then that allowed us to compare the tumor margin as well as the ablation volume, expected ablation volume, and did we cover the entire tumor? And so if you look at the models on the right, so those are each of the tumors. So that's the actual 3D model of the surface of the tumor. And then projected on it, the coloring is the actual margin that we anticipated based on the 3D ultrasound. So at every point, you'll notice the darker blue suggests a margin kind of in 10 to 15 millimeters. White is essentially the edge of the ablation zone just touched the edge of the tumor. And then anything orange to red means that the tumor went beyond our expected ablation area. So you can see numbers 2, 5, and 6 actually have some orange on there, suggesting they were predicting that we likely would have some residual and not have treated the entire tumor. And sure enough, when we saw those patients on follow-up, those 3 all had either residual at that site or new disease on the post-ablation follow-up. Whereas all the other ones where we on 3D ultrasound predicted that we had complete ablation, complete coverage, their initial follow-up showed no cancer remaining. So that showed some of the feasibility. We wanted to see, can we take this a step further? Okay, now we're saying there is some left behind. Could we propose how the needle needs to be adjusted? So using those 3, the model of the tumor, the surface, and the coverage, we actually plotted. So if you look at these plots, we developed a uniformity index. So along the bottom is essentially the surface, different surface points along the tumor, and the margin is shown along the y-axis. So what we ideally want is something horizontal. So if you can see along that top left, the centroid, that's sort of our ideal scenario. We want a horizontal line, all the points closer together. And then if we were in too deep, we'd see one end kind of sticking up. If we're too shallow in our position, then the other end would stick up. What that allows us to do is just pictorially kind of see very quickly how the needle could be adjusted. So for example, for patient 2, we can see that the needle actually here was probably in a little too deep. And as a result, we just had to pull it back. Then we probably would have been able to cover that orange section a little bit better than was covered at the time. Whereas patient 5, you see, is very horizontal to the line. So there's no extra margin that we could see. This was a scenario where really the tumor was too large for the ablation needle that we're proposing. So it was optimally positioned, but the technology was just not optimal to be able to treat that type of tumor. And we found that using some of the corrections based on that, we were able to, of the 14 tumors that we treated, we were able to move 4 of them from incomplete or insufficient ablation to more optimal. And like I said, patient 5, we felt actually couldn't be addressed. So the final task, we want to look at system integration. We built all these individual pieces. We've now established a way to fuse our preoperative imaging so that we can have that for guiding us. We also have the needle guidance where we can track the needles under 2D real-time ultrasound, confirm needle position. And so our last task is try and put everything together. Like I say, we've developed this mechatronic arm that can track the position. So we're incorporating it into an overall ablation system. We measured what is the accuracy of our tracking in space. And here you can see some of the errors that we have in tracking the arm are relatively low. And then we looked through our workspace within the 3D ultrasound system as we moved to different spots. And as you can see, our errors are all generally within about 5 millimeters, both looking not only at the point position, but the actual plane orientation. So in summary, these are kind of our 4 tasks. I think we've, in our opinion, completed tasks 1 and 3. We're about 70% of the way there on task 2 of the needle segmentation, and about 80% of their way there in the system integration. And we're looking forward to do some clinical trials going forward. So in summary, our 3D ultrasound system, we feel, will improve ablation procedure over 2D ultrasound alone. By providing tumor identification, improved needle guidance, and needle position. Thanks very much. And I just